Thanks a lot, Pratik and Dr. Anuradha, for giving me this opportunity. And I'm going to start this session by discussing the issues with the tissue. We know that in the current era, there are many molecular drivers have been described in the lung cancer, and they play a very vital role in the management of lung cancer. So at the same time, there is a responsibility for the pathologist has enhanced immensely, and because we have to because this tissue need to be subjected not only for the morphological assessment, but also for the various number of the molecular diagnostic tests, and hence this has caused a revolution in the field of lung cancer, and a great responsibility has come in the hands of a pathologist, and there is no escape from them. So the major issues which as a diagnostic pathologist which we face, first is the acquisition of adequate sample, which should be sufficient to do all these desired investigation, adequate processing of the sample, and which method to be used for these various molecular tests. So starting with the sample. About the sample, although it is a role of a intervention radiologist to provide us a good quality of the sample, and it should be not only the quality, both quality and the quantity of this tissue should be adequate, and there are various methods or in the imaging room are used to this, and there are variable diagnostic yields and for the adequacy, but for the method which method should we choose is based on the whatever method which can give a good tissue to the pathologist, and that all depends upon the number of depending on the where the lesion is located, and what are the clinical requirements. So we have to keep in mind any repeat biopsy, it overburden the healthcare system as well as waste a lot of resources and cause delay in the patient management. So some few recommendations for acquisition of the samples. We have to ensure that minimum of 3 cores per tumor should be provided. The biopsy from the different areas are to be sampled, and whenever feasible, if you have a fluid sample or cytology sample, it need to be converted to cell block so that the various molecular tests can be performed, and pathologists should be even available in the intervention room so that they can assess the adequacy on site. So if anything need to be repeated, should be done at the same sitting. So there are few recommendations which are provided recently by the College of American Pathologists to handle small biopsies and cytology specimen, and these recommendations strongly recommend the use of ROSE, that is a rapid on-site evaluation technique, whenever we are extracting the tissue for the lung cancer tumor. In addition, there are few recommendation also endorse that cell block should be prepared whenever feasible, and all the tissue should be fixed in the 10% neutral buffer formalin. Next comes the role when the sample reaches the lab. It is all the responsibility of a pathologist, and we have to act as a guardian of these precious samples, and the tissue should be processed not only for the diagnosis, but with the aim that we have to save the tissue for the molecular diagnostics. So once the tissue come out of body, there is a cold ischemia starts, and the tissue need to be properly fixed as soon as possible, so that the further degradation of the DNA as well DNA and could not happen. There are two ways we can handle this tissue once it comes out. Either we can snap froze it immediately, or it need to be fixed in the formalin. There are advantage and disadvantage of both these methods when we when we consider it with respect to the molecular test, the fresh frozen samples, they are considered to be superior because they might give a good quality nuclear acid yield, but handling of these specimen is very challenging, and and even archival of these tissue is quite expensive. So routinely the paraffin embedded tissue is used, and there are many companion diagnostic assays are also now standardized and validated while using this formalin fixed paraffin embedded tissue, because it is easy to handle, relatively cheaper. But the problem is that the processing protocols for formalin fixed paraffin embedded tissue are not very standardized, and which may compromise the quality of the tissue. So how we should handle this tissue? First and foremost important is that immediate and prompt fixation with the adequate and standardized tissue processing is required. And we have to keep in mind both under fixation and over fixation can cause harm to the tissue. So this thing need to be kept in mind, and the tissue can be fixed and processed only once. We have to keep this another thing in mind, so that if the harm is done in the beginning, you can't rectify it. A few recommendations to increase diagnostic yield of the sample. So with a sample, although these are they are small biopsies, they should also be divided into two blocks, and we routinely make two blocks, and one block we do the diagnostic work, and other block we send for the molecular. It has to be kept in mind that the only expert technicians should handle these precious tissue. Otherwise, so we have seen some of the unexperienced histotechnicians, they waste a lot of tissue, and sometimes they give multiple serial, which is of no use, especially if you are dealing with a malignancy. And this information should be communicated to the laboratory person, and then after once the tissue is processed and slides are made, now the role of pathologist comes, and we use this tissue for not only for the morphological evaluation but also for the IC and molecular workup. So diagnostic recommendation for the pathologist: if you have more than one material, evaluate that together. Why it is important? Because you might save on some of your ISCs, and although as per recent WHO recommendations, some minimum ISCs are recommended, but we have to use the ISCs judiciously and depending on the basic morphology. And these are some indications in which we have to mandatorily do immunohistochemistry. So in interest of time, I'll just skip the detailed description on about it. Next, once the diagnosis is come, now the role of molecular diagnosis come, and the first and important role which which a pathologist play is about the adequacy of the tumor and the selection of adequate block for the molecular diagnosis. So because we have to keep in mind the tumor, the tissue whichever we get is always not a pure tumor. Around 30 to 50% of it might be fibrosis, necrosis, or tumor might be completely necrotic. And so we have to evaluate the tissue both in terms of its quality as well as its quality. And even at the end of our report, we put this impression, and even now we have started putting exact percentage of the tumor content in our report, so that both clinician as well as the person sitting in the molecular lab, they are aware that the tissue is adequate. About for which tissue to be tested, now with the advances in the technologies, now we can do the molecular testing by any tissue, right from the biopsy to the cytology, as well as many tests are now feasible on the blood samples. Briefly about the tissue requirements, because there are various different tests which we have to do for routine diagnosis. You need at minimum of 3 sections, including 2 for ISC, and then next steps, if you are doing sequential testing, then for EGFR 4 sections of 10 micron meter is required. And then further requirement of the tissue can vary depending on whether you are doing IC based biomarkers or the fish based biomarker. So for both of them, the 3 to 4 micron 6 sections are required for IC based marker, and minimum of 50 cells should be there for fish based analysis. And if you are going for NGS based test, Then again, similar to the EGFR based assay, you need a minimum of 4 sections of 10 micron thickness, but considering that at least tumor has 20% of the tumor content. So commonly the practice which is still in many places in India is to do the sequential testing, and all this whenever you cut the block at for different tests at different time points, you lose the tissue. So although this is a financially viable option, but and the information to the clinician about the test become is available early, but it can lose cause loss of data, and even if you are not able to perform the detailed molecular analysis by NGS, limited information will be conveyed to the clinician. So this is a summary of what I told you. The both at the acquisition of the sample as well as at the pathologist level, we have to practice those techniques which can save maximum amount of the tissue for molecular testing. And as we know now, there are a variety of the tissues which are available, right from the tissue cytology and blood samples, and different technologies also available, and we have to use all of them so that we can give a comprehensive and conclusive report to the clinicians. Also, although there are various technologies are available, but the first point is the tissue, and we have to handle it judiciously. So if we can't handle it, it will be like a garbage in, garbage out, and we will be losing lot of resources and time on these high-end molecular tests. So with this, I end my talk and open for any questions. Pratik, are you there?
Yes, I'm here. So I will pass on questions to you over the chat box, and maybe we can cover it after the session.
Okay.
But right now, because of time constraint, we will proceed with the next.